Welcome to the deep dive. Today we're looking at something really crucial in vascular health.
We are indeed. It's about how doctors figure out what's happening inside your arteries, especially in the legs.
Right, moving beyond just, feeling for a pulse, we're talking objective evaluation.
Exactly. And while there's some really advanced imaging now, these non-invasive physiologic tests still incredibly important in certain situations.
So think of this as your mission for this deep dive.
Yeah.
Understanding how doctors use these non-invasive methods to check blood flow. We're talking arteries, legs mainly.
Yeah, and our sources for this, we're digging into some key textbook chapters, Rutherford's vascular surgery and endovascular therapy, pretty much the gold standard stuff.
Solid foundation then. And these sources really stress how vital these tests are when maybe the diagnosis isn't totally clear-cut.
Yeah, like telling the difference between leg pain from bad circulation versus, say, a nerve problem like neurogenic claudication.
That's a big one. And also figuring out how much the arterial disease is actually limiting someone's walking, especially if they've got other things going on, like arthritis.
And here's something interesting. They can even pick up early signs in people who don't have any symptoms yet.
Which is huge for thinking about overall heart health risk.
Absolutely. Plus, for folks with more advanced disease, these tests help guide treatment. Like, will this ulcer heal? Where's the best place for an amputation, if it comes to that? It gives objective data.
Okay, so where do we start? What's the foundational tech here?
It really comes down to Doppler ultrasonography. That's the bedrock for a lot of this.
Doppler. Heard the name. Probably most people have.
For sure. It lets us non-invasively look at blood flow, analyze those velocity waveforms. It's fundamental for peripheral artery disease, or PAD.
All right, let's unpack Doppler then. Starting simple, the continuous wave kind, those little handheld devices.
Yeah, the pocket Dopplers, they usually run at about 5 to 10 megahertz.
Why that frequency range specifically?
It's a good compromise, really. Gets you decent penetration for arteries, fairly close to the skin, but still enough resolution. Higher frequencies, better picture superficially, but they don't go as deep.
Okay, and inside the probe, you've got these crystals.
Piezoelectric crystals, yep. One sends out the ultrasound wave, the other listens for the echo coming back.
Send and receive. Simple concept.
But you need something to help the sound waves actually get into the body efficiently.
The gel.
Exactly, that aqueous gel. It cuts down on the sound energy loss just going from probe to skin. Then the key thing happens. Those waves hit moving red blood cells.
And bounce back.
They bounce back. And here's the magic, the Doppler effect. The frequency of that returning wave changes based on how fast those red cells are moving and whether they're coming towards or going away from the probe.
Faster flow, bigger change in frequency.
Precisely. And there's an equation for it, the Doppler equation. Phi 2v Vescio cussa C.
Whoa. Okay, formula time. Break that down for us.
Sure. A is the frequency shift. That's what we actually measure. V is the blood velocity we want to know. S0 is the original ultrasound frequency we sent out.
Got it. VS0. What about the costi?
Costi accounts for the angle between the ultrasound beam and the direction the blood's actually flowing. It's super important for accuracy. And C is just the speed of sound in blood, which is basically constant.
Okay, so the machine calculates all that from the frequency shift it detects.
Well, the simplest devices convert that frequency shift directly into an audible sound.
So you can hear the blood flow.
You can. And you interpret it. The pitch of the sound tells you about velocity, higher pitch, faster flow, often means that narrowing.
And the loudness.
Loudness, or amplitude, gives you a sense of the volume of blood moving in the beam. More cells, louder sound.
What about the quality of the sound? Like staticky?
Yeah, a harsh, noisy sound usually points to turbulent flow, disturbed flow.
Yeah.
A trained ear learns to pick that up.
Fascinating. So what does a normal, healthy leg artery sound like when someone's just resting?
Typically, you get what's called a triphasic or maybe diphasic sound. It has distinct parts.
Triphasic. 3 phases.
Right. You hear a strong whoosh forward during systole when the heart pumps. Then, because the downstream vessels have high resistance, you get a brief reverse flow sound, a little blip back.
Okay. Forward, then back.
And sometimes, in late diastole, a smaller bit of forward flow again. That's the tri part. Biphasic is just the first two, forward and reverse.
What changes that pattern, say, after exercise?
Yeah.
The resistance downstream changes then, right?
Exactly. After exercise or in vessel beds that normally have low resistance, like the brain or kidneys, that peripheral resistance drops. The reverse flow bit disappears.
So it just becomes
Monophasic, just forward flow throughout the whole cycle. That's a normal response to needing more blood flow.
But what if there's a blockage? An actual obstruction. How does that sound?
An obstruction dampens everything. The waveform becomes low amplitude, usually monophasic too, but weak.
Could you confuse that with a vein?
Sometimes. But you can do things like gently squeeze the foot, you'll hear a surge from the veins emptying, or use a directional Doppler, which tells you if flow is towards or away from the probe. Arteries and veins usually flow differently relative to the probe position.
Ah, neat tricks.
Yeah.
You mentioned qualitative versus quantitative analysis of these waveforms. What's the difference?
Qualitative is the experienced listener interpreting the shape and sound. Like, the very earliest sign of a narrowing, a stenosis, might just be a slight broadening of the sound spectrum, especially in early diastole. Things get less uniform.
Spectral broadening.
Okay.
And as it gets worse.
The peak velocity sound gets higher pitched, faster, and that spectral broadening becomes more obvious.
What about a really significant narrowing, say 50% blocked or more?
A key sign there is often a doubling of the peak systolic velocity compared to the artery segment right before it.
A doubling. Wow.
Yeah, and downstream from that tight spot, the waveform sound gets really blunted, monophasic, turbulent. You might hear that high-pitched, noisy jet sound right at the stenosis, and the turbulence carries downstream a bit.
And upstream, before the blockage.
Upstream, the blockage increases resistance. So you might get less forward flow sound and a more prominent reflected wave sound, sometimes called a to and fro signal.
Are there limits to this handheld Doppler?
Definitely. Very, very low flow states can be tough to pick up. The signal might be too weak, or the machine's filters might cut it out.
So for more detail, you need something more advanced. Spectrum analyzers.
Exactly. They process the Doppler signal mathematically and show you the whole range of frequencies over time, usually as a graph with frequency or velocity on the y-axis, time on the x-axis, and the brightness or grayscale showing how many blood cells are moving at each velocity.
So you can see the spectral broadening instead of just hearing it.
Precisely. Smooth laminar flow looks like a narrow, clean line or band on the display. Turbulent flow, spectral broadening, looks like the band is smeared out, wider, much more objective.
And these are part of duplex scanners.
Yes. Duplex combines the B-mode imaging, the grayscale picture of the artery structure, with Doppler, usually pulsed Doppler.
Pulsed, how's that different from the continuous wave we started with?
Pulsed wave Doppler lets you select a specific small area, a sample volume, at a specific depth. So you can measure velocity precisely at the stenosis or just upstream or just downstream while seeing the artery image. It's key for accurate grading.
Makes sense. You also mentioned some indirect waveform stuff at the groin, the common femoral artery.
Yeah, things like pulsatility index, Laplace transforms, ways to quantify the waveform shape to try and guess if there's blockage higher up in the aorta or iliacs.
But they have limitations.
They do. A waveform can sometimes look surprisingly normal at the femoral artery, even with significant disease upstream, especially if collateral vessels have developed. So not foolproof for aortoiliac disease assessment just by looking at the groin.
Okay, so Doppler is fantastic for flow velocity and patterns. But PAD is also about pressure, right? How do we measure that non-invasively?
Right. That brings us to non-invasive pressure measurements, pioneered by Dr. Strandness and his team back in the 60s, actually often using those same continuous wave Dopplers.
Using Doppler to measure pressure. How?
Well, the core idea is simple. Flow happens because of a pressure difference, a gradient. So if the pressure drops significantly across a section of artery, it implies there's resistance, a blockage, reducing flow. Measuring pressure changes is often more practical than trying to measure absolute flow rates in the clinic.
Okay, and what part of the pressure reading is most revealing?
Systolic pressure. Changes in the peak pressure are much more sensitive to the effects of a stenosis than changes in the mean or diastolic pressure. The narrowing dampens those higher frequency components of the pressure wave.
Why does the pressure drop across a stenosis?
Two main reasons. Friction, or viscous losses, as blood squeezes through the narrow bit, and energy loss to turbulence.
Turbulence again. Does that relate to the Reynolds number you hear about in fluid dynamics?
Exactly. The Reynolds number helps predict when flow transitions from smooth, layered laminar flow to chaotic, swirling, turbulent flow. It depends on velocity, vessel diameter, and blood viscosity. Higher Reynolds number means more turbulence, more energy loss, bigger pressure drop.
So a minor narrowing might not cause a pressure drop at rest.
Correct. Low flow, low velocity, maybe no significant drop, but make the blood flow faster, like during exercise.
Then the pressure drop shows up.
Then it becomes apparent. Generally, a drop in peak systolic pressure of about 10 millimeter Hg at rest, or maybe 15 millimeter Hg after inducing hyperenemia increased flow, suggests that narrowing is hemodynamically significant. It's impeding flow.
But there's a catch.
There is. If you have really severe disease downstream, limiting the overall flow significantly, then even a tight stenosis upstream might not show much of a pressure drop, even with hyperemia. Minimal flow means minimal pressure drop, no matter how tight the upstream blockage is.
That's a really important point.
Hmm.
Okay, let's talk about probably the most common test people hear about.
Yeah.
The ABI, ankle brachial index.
Absolutely fundamental. It's a cornerstone for lower extremity PAD assessment.
How's it done? The basics.
You put a regular blood pressure cuff just above the ankle, then you use the Doppler probe over one of the main arteries there, usually the posterior tibial or the dorsalis pedis.
Okay.
You inflate the cuff, then slowly let the air out, listening with the Doppler. The pressure reading, when you first hear the arterial signal return, that's your ankle systolic pressure. You usually check both arteries and take the higher value for that leg.
And sometimes a peroneal artery too, if needed.
Yes, if you can't get a good signal from the other two, the peroneal is the backup.
And you compare that ankle pressure to the arm pressure.
Right. You measure the brachial systolic pressure in both arms, usually with the same Doppler technique over the brachial or radial artery. You use the higher of the two arm pressures as your reference.
Why the higher arm pressure?
Because that brachial pressure is acting as a stand-in for your central aortic pressure. You want the best estimate of systemic pressure, and subclavian artery stenosis could falsely lower the pressure in one arm. So using the higher arm pressure avoids underestimating the ABI if there's an issue in one arm.
Makes sense.
Yeah.
So for each leg, highest ankle pressure divided by the highest brachial pressure. That gives you the index, the ABI.
That's it. And using the ratio, the index, makes it less variable than just looking at the absolute ankle pressure alone.
What's a normal ABI? What do the numbers mean?
Generally, 0.90 up to about 1.29 or 1.3 is considered normal.
What about just below 0.9?
That 0.90 to 1.00 range is often called borderline. It suggests an increased cardiovascular risk, even if not definite PAD yet. As PAD gets worse, the ABI drops further.
And over 1.3? That seems weirdly high.
It is. An ABI over 1.3 usually means the ankle arteries are stiff and calcified, so you can't compress them properly with the cuff. You get a falsely high-pressure reading, often seen in patients with diabetes or chronic kidney disease.
So the ABI isn't just about the legs right now. It tells you about future risks, too.
Definitely. It's well validated against angiography for finding significant stenoses, maybe over 50% narrowing. Sensitivity can vary a bit depending on the exact cutoff you use for normal, and the patient group may be slightly less sensitive in the elderly or diabetics.
Right, because of that calcification issue.
Exactly. But overall, it's a good indicator. And lower ABIs strongly predict progression to critical limb ischemia, rest pain, ulcers, gangrene.
Overall health.
Yes. Both very low ABIs, say below 0.6, and those falsely high ones above 1.3, are linked to increased mortality, mainly from cardiovascular causes. Even a declining ABI over time is a bad sign.
So should everyone get screened with an ABI?
That's debated. Guidelines often suggest it's reasonable for screening certain higher risk groups, maybe people over 65 or diabetics over 50, even without symptoms. A low ABI marks them as high risk for heart attack and stroke.
But does screening actually prevent those events?
That's the weaker part of the argument.
Yeah.
There isn't strong evidence yet that just finding PI via ABI screening in asymptomatic people leads to interventions that definitely prevent heart attacks or strokes, or that it adds much beyond standard risk factor assessment like cholesterol, blood pressure, smoking status.
So routine checks if you feel fine aren't really recommended.
Not typically, no. We usually check it if someone has symptoms, or maybe as a baseline in high-risk folks, but not yearly surveillance without reason.
What about differences between men and women?
It's interesting. Some large studies hint that women with a low ABI, below 0.9, might actually have higher rates of cardiovascular events than men with similar low ABIs, but it's not fully defined across all ABI ranges.
The key thing is women get PA too.
At least as often as men, so the testing is equally important for everyone.
Are there common ways to mess up an ABI measurement? Technical errors?
Oh, absolutely. Several pitfalls. One is using the brachial pressure from the same side arm instead of the higher of the two arms. That's a no-no.
Okay, always use the higher brachial. What else?
Not letting the patient rest supine flat for long enough beforehand. Needs to be at least 5, preferably 10 minutes. If they just sat up or walked in, gravity affects the ankle pressure, giving a false reading. Hydrostatic pressure.
Resting is key. Cup size.
Critical. Too small a cuff, pressure reads artificially high. Too big, reads low. The AHA has specific guidelines based on limb circumference. Got to use the right size.
We mentioned the calcification issue ABI over 1.3. How do you spot that if the number looks okay, say 1.1, but you're suspicious?
Good question. Clues include hearing a really blunted monophasic Doppler signal at the ankle despite a decent pressure number, not being able to feel a pulse even though the pressure seems okay. Or a neat trick. See if the Doppler signal diminishes or vanishes when you just passively lift the patient's ankle off the bed while they're supine.
The elevation test.
Yeah. If the signal drops out easily, suggests the arteries might be stiff. And in any case where you suspect falsely high ankle pressures due to calcification.
Measure the toe pressure instead.
Exactly. Toe pressures become much more reliable then.
Okay, moving down the leg.
Yeah.
Segmental pressures. Adding more cuffs.
Yep. Cuffs usually at the upper thigh, above the knee, below the knee, and ankle. Plus the arm cuff. You measure the pressure at each level using the Doppler at the ankle.
And you're looking for pressure drops between the cuffs.
Right. A drop of 20 millimeter Hg or more between adjacent cuff levels points towards significant disease in that segment.
I heard thigh pressure can be higher than arm pressure normally.
It often is, especially with standard thigh cuffs. Some pressure wave amplification happens, but also be aware a tight thigh cuff could potentially restrict outflow and mask a pressure drop across a blockage higher up. It's a bit complex.
What can segmental pressures tell you?
They're not great for disease below the ankle or in arteries that branch off, like the deep femoral artery, the profunda femoris. Also, if you have a really bad blockage high up, it drops all the downstream pressures, making it hard to tell if there are other, maybe milder blockages further down.
So comparing side to side is important.
It helps if the disease is asymmetric, but if both legs have similar disease, side-to-side comparison won't show much difference, even though there's significant PD.
You mentioned the profunda artery. There's a specific index related to that.
Yes, the profundopopliteal collateral index, or PPCI, used when the main superficial femoral artery, SFA, is blocked. It estimates how well collateral vessels, mainly via the profunda, are supplying blood around the knee.
How's it calculated?
You take the above knee pressure minus the below knee pressure and divide that difference by the above knee pressure.
And what does that tell you practically?
A lower PPCI suggests good collateral flow. Maybe a simpler surgery focused on the profunda, a profundoplasty, would be enough. A higher PPCI. Poorer collaterals might need a more extensive bypass. Help surgical planning?
Do these segmental pressures add much diagnostic accuracy beyond just ABI and looking at the Doppler waveform?
Current thinking is probably not significantly, and they take time, can be uncomfortable, maybe even risk damaging stents theoretically. So they're often combined with pulse volume recording, PVR, which gives different info.
Let's circle back to toe pressures. You said they're key with calcified arteries.
Yeah.
How are they actually done?
You use a tiny cuff, like a miniature blood pressure cuff, around the base of the big toe, usually. Then you need a sensitive way to detect flow returning as you deflate the cuff.
Not Doppler.
Can be a tiny Doppler probe, but more often it's photoplethysmography, PPG, a little light sensor clicked onto the end of the toe, or sometimes a laser Doppler.
And why are they so useful, besides the calcification issue?
They assess perfusion right down at the end of the line. Good for picking up disease just in the foot arteries, which the ankle pressure might miss. Really tells you about the circulation where ulcers often happen.
What are the numbers we look for with toe pressures?
Normal toe pressure is usually maybe 20 to 40 millimeter Hg lower than the ankle pressure. We often calculate a toe brachial index, or TDI. Below 0.7 is generally abnormal.
And for symptoms or healing?
Ischemic rest pain often starts when toe pressure drops to 30 millimeter Hg or less. For ulcer healing, you generally want to see a toe pressure above 50 millimeter Hg, maybe even higher in diabetics.
Are there times you can't get a toe pressure?
Yeah, if there's significant gangrene or tissue loss on the toe itself, it can be impossible to place the cuff or the sensor properly.
Okay, we've covered resting measurements extensively, but PA symptoms often show up with activity, so stress testing.
Absolutely vital, because that pressure drop across a stenosis is flow dependent, right? A mild narrowing might look fine at rest.
But cause problems when you demand more flow.
Exactly. Stress testing quantifies that functional limitation.
The classic stress test is the treadmill test. When do you use that?
Cue indication is someone with classic claudication symptoms, leg pain with walking, but their resting ABI is normal or borderline. Helps confirm the diagnosis.
What else?
Also great for differentiating arterial claudication from neurogenic claudication, that's spinal stenosis mimicking PAD. And if someone has multiple issues like PAD plus bad arthritis, it helps figure out how much the PAD is actually contributing to their walking difficulty.
What's the standard treadmill protocol?
Usually, after measuring resting ABI supine, they walk on the treadmill at a standard speed and incline maybe 2 mph at a 10 or 12-degree grade.
For how long?
Up to 5 minutes, or until their symptoms force them to stop. We note when the pain starts and when they stop,
And then measure ABI again.
immediately after stopping. And then every minute or two for maybe 5–10 minutes to see how quickly it recovers back to baseline. Cuffs stay on during the walk.
How do you interpret that?
If they walk to full time with no symptoms and no significant drop in ABI, it pretty much rules out flow-limiting PI. If the ABI drops, the amount it drops and how long it takes to recover tells you about severity.
So a bigger, longer drop means worse disease.
Generally, yes. And patients with only a small drop, say less than 20 millimeter Hg from resting ankle pressure, often don't get much benefit from surgery.
Are there exceptions to that standard protocol?
Yes, sometimes in high-level athletes with suspected iliac artery endofibrosis, a rarer condition, you might need a more intense exercise protocol to bring out the pressure drop.
Does treadmill testing work equally well for disease anywhere in the leg?
It tends to be more sensitive for disease higher up aortoiliac or femoral disease, less sensitive if the blockage is only below the popliteal artery in the calf vessels.
What if someone physically can't do the treadmill test?
No.
Other health issues.
Good point. The main alternative is reactive hyperemia testing.
How does that work? No walking involved.
No walking. You put a cuff on the thigh, inflate it way above their systolic pressure for 3 to 5 minutes to completely cut off blood flow.
Sounds uncomfortable.
It can be, yeah. When you suddenly release the cuff, the downstream vessels dilate like crazy, trying to repay the oxygen debt, causing a big surge in blood flow.
Mimicking the increased flow of exercise.
Kind of. We then track the ankle pressure response right after cuff release. Normally it dips briefly, then recovers quickly. With PAD, the drop is often similar to exercise, but the recovery might be a bit faster. The size of the drop and recovery time correlate with disease severity.
What are the pros and cons versus the treadmill?
Pros: faster, less equipment, doesn't require patient motivation or ability to walk, maybe easier to standardize. Cons: less specific and sensitive usually, uncomfortable, more operator dependent, and crucially, it doesn't actually test their walking ability.
So duplex scanning might be preferred if treadmill isn't possible.
Often, yes. Or sometimes reactive hyperthermia is used just to assess endothelial function in the arm, the brachial artery reactivity test, which is a different application.
Okay. What about getting the ultimate pressure reading, sticking a needle right in the artery? Direct pressure measurement.
Yeah, that's the invasive option, usually reserved for when imaging and all the non-invasive tests leave some uncertainty about whether a specific stenosis is truly significant, truly limiting flow.
When would you do that?
Maybe done during surgery, or more commonly now, during an angiogram. You put a pressure wire or catheter across the stenosis.
How do you measure the drop?
You measure pressure before and after the narrowing. Ideally, you compare it simultaneously to a reference pressure from another artery, like the radial in the wrist, using the same transducer setup to be really accurate.
Can you stress the artery during this?
Yes, if the pressure gradient at rest is borderline, you can give a vasodilator drug to maximize flow and see if a significant gradient appears then. It's also great for pinpointing problems in bypass graphs. It's considered the gold standard reference for pressure gradients.
Makes sense. Let's shift gears slightly. Penile pressures. Why measure blood pressure there?
It relates directly to erectile function. The cavernosal arteries need good inflow for an erection. Blockages higher up iliac or pudendal arteries can cause vasculogenic erectile dysfunction.
So it helps diagnose a physical cause for ED.
Exactly. Differentiates it from hormonal or neurological causes.
How's it done? Tiny cuff again?
Yep. Small penile cuff at the base. Then you need flow detection. Could be an old-school mercury strain gauge, PPG sensor, or a Doppler probe. There's some debate about exactly where to put the probe dorsal arteries versus cavernosal arteries.
What's normal penile pressure?
Should be about the same as the brachial systolic pressure. We calculate a penile brachial index, PBI, normally above 0.75 or 0.80. Below 0.6 is pretty diagnostic for vasculogenic ED, especially if they have other PAD signs.
And the pressure difference?
The brachial penile gradient. Less than 20–40 millimeter Hg difference suggests adequate flow. More than 60 millimeter Hg difference suggests significant insufficiency. It does tend to decline naturally with age, though.
Okay, we've hit Doppler and pressure thoroughly. What about plethysmography, measuring volume changes?
Right. Plethysmography looks at changes in limb volume due to pulsatile arterial inflow. Older methods use mercury strain gauges wrapped around the limb circumference, changes stretched the gauge, changing resistance. Or impedance plethysmography measured electrical impedance changes.
But those aren't common now for PA.
Not really. They've largely been replaced by air plethysmography, which most people know as pulse volume recording or PVR.
PVR, how does that work with air?
Uses cuffs again at different levels, thigh, calf, ankle, maybe foot. But these cuffs are inflated to a low pressure, typically around 65 millimeter Hg, enough to make contact and sense volume changes, but not enough to impede flow.
And the machine senses pressure changes within the cuff.
Exactly. Each heartbeat pushes a pulse of blood into the limb segment under the cuff, making it expand slightly. That tiny expansion compresses the air in the cuff, causing a tiny pressure rise. The machine records these pressure fluctuations as a waveform.
So you PVR waveforms at different levels. What do they normally look like?
A healthy PVR waveform has a sharp, rapid upstroke, a nice pointed systolic peak, usually a dichrotic notch on the way down, and then the downslope bows nicely back to baseline.
And blockages mess that up.
They do. An upstream stenosis dampens the waveform. The upstroke gets slower, the peak gets rounded, the dichrotic notch often disappears, and the overall height, the amplitude, decreases.
So less pulsatile flow means blockage upstream.
Generally, yes. Though severe disease further downstream can also affect the waveform shape proximally, so it's not perfectly simple.
Is the amplitude reduction the main thing you look at?
Not solely. Amplitude varies a lot between people based on heart function, blood pressure, etc., so we look more at the shape changes. There are grading systems, normal, mildly, moderately, severely abnormal, based on the loss of the dichrotic notch, the rounding, the slope.
Does exercise affect PVRs?
In normal limbs, amplitude usually increases after exercise because flow increases. In a limb with a flow-limiting stenosis, exercise might actually make an abnormal waveform look even worse or bring out abnormalities not seen at rest.
What's a key advantage of PVR compared to, say, ABI?
It's much less affected by calcified arteries. Those stiff vessels don't stop the limb from expanding with each pulse, so PVR can be really useful in diabetics or kidney patients where ABI might be unreliable.
So combining PVR with segmental pressures is common.
Very common. Gives you both pressure gradient info and waveform shape info. More accurate together than either one alone. There's debate if duplex ultrasound should replace these, but PVR is often faster, maybe needs less specialized skill, and gives a good sense of overall limb perfusion and collaterals. Still has a role.
And you can do this on toes, too. Digital plethysmography.
Yep, usually with that PPG sensor we mentioned for toe pressures, clips onto the toe.
Why do that?
Again, great for when ankle arteries are calcified or if you suspect disease just in the very small vessels of the foot or toes. The PPG sensor shines infrared light and measures reflected light changes due to blood volume pulsations in the capillaries.
And the waveform shape tells you about proximal disease.
It can reflect it, yes. If you have abnormal digital waveforms and pressures, but okay ankle pressures, it points strongly to disease distal to the ankle. Also used for Raynaud's evaluation, looking for vasospasm, or checking for Steele syndrome with dialysis fistulas.
What does a normal digital waveform look like?
Similar to the larger limb PVRs, sharp upstroke, dichrotic notch. Blockages dampen it, round it, make it disappear eventually. A normal digital waveform is pretty reassuring for the arteries supplying that specific toe.
Can you do reactive hyperemia with digital PVR?
You can. The idea is that in severe PAD, those tiny resistance vessels are already wide open trying to get blood, so they don't dilate much more after occlusion.
How's the test done?
Cuff at the ankle or above, inflate, hold, release rapidly. Monitor the digital PVR on the toe.
What's the normal response?
Pulse should come back fast, amplitude should recover to at least half the baseline within seconds, and then often overshoot, maybe doubling baseline amplitude briefly.
That with PA?
Delayed return of the pulse takes longer to get back to half baseline. The worse the disease, the longer the delay.
Does this relate to the sympathetic nervous system?
Somewhat. The response depends partly on resting sympathetic tone. It's sometimes used to predict if a sympathectomy surgery might help if the pulse amplitude doesn't increase much after hyperemphysema. Maybe the sympathectomy won't improve flow significantly either. But it doesn't test if the nerves themselves are intact, need other tests like a deep breath response for that.
We've covered a huge amount. Doppler, pressures, PVR. Are there other ways to look even closer at the microcirculation level?
Yes, methods that try to assess the actual tissue effects. Things like transcutaneous oxygen tension, TCPO2, laser Doppler again, hyperspectral imaging, cold testing, capillaroscopy, more specialized stuff.
Let's touch on TCPO2, measuring oxygen through the skin.
Essentially, yes,
Yeah.
it measures the partial pressure of oxygen that diffuses out of the capillaries through the skin, gives an idea of tissue oxygenation, the balance between delivery and consumption.
How do you measure it?
Special electrodes placed on the skin foot, calf, maybe thigh, often with a reference on the chest. They have a tiny heater warming the skin to about 45 degrees C,
Why the heating?
maximizes local blood flow, and makes oxygen diffuse out more easily to the sensor. The sensor then generates a current proportional to the oxygen level.
So low TCPO2 means low oxygen, likely due to poor flow.
It's not always that simple. It's actually not very sensitive to mild or moderate PAD, because even then, oxygen supply often exceeds the skin's resting demand. The reading might only drop when flow is critically low.
What else affects it?
Lots of things. Skin temp, edema, inflammation, which increases oxygen use, how thick the skin is, overall oxygen levels in the blood. It can be quite variable and unreliable sometimes, which limits its popularity.
So when is it most useful?
Primarily in severe ischemia, especially for predicting wound healing or choosing an amputation level. Unlike pressure readings, it's not affected by arterial calcification. That's its main strength.
What are typical values?
Depends on age and location, but generally over 55 millimeter Hg is normal at rest. Distal sites are more sensitive. Healing is often poor if TCPO2 is down in the 20-40 millimeter Hg range, maybe even lower.
Can you enhance the test?
Yes, see how it changes with leg dependency, might increase more in severe PAD. Exercise usually drops in ischemic feet. Reactive hyperemia, or breathing extra oxygen. Normally, breathing O2 should raise TCPO2 significantly. In PA patients, the increase is often much smaller.
Okay, and briefly, laser Doppler and skin perfusion pressure.
Laser Doppler, as we mentioned, uses laser light to detect red blood cell motion in the very superficial skin layer, about 1.5 millimeters deep, gives a signal proportional to flow velocity in that tiny volume.
Qualitative mostly.
Yes. Shows pulsations and slower vasomotor waves. PA tends to flatten the waveform, reduce velocity, lose the vasomotor waves. Hyperemic response is less, generally less predictive than TCPO2 for healing.
But you can use it to measure pressure, skin perfusion pressure.
Right. Put the laser probe under or distal to a blood pressure cuff. Inflate the cuff, then slowly deflate. The pressure at which the laser Doppler signal shows flow returning is the skin perfusion pressure, or SPP.
What are the numbers there?
Normal SPP may be 50-70 millimeters Hg, often drops to 10-20 millimeter Hg or with significant PAD. Below 30 millimeter Hg is often linked to critical limb ischemia. Some studies suggest combining SPP over 40 and toe pressure over 30 predicts wound healing well.
Wow, that was a really comprehensive tour of these non-invasive techniques. Let's try to summarize the big categories.
Okay, we started with Doppler ultrasound, looking at flow velocity, waveform shapes, using continuous wave and pulsed wave.
Then pressure measurements.
Right, the cornerstone ABI, then segmental pressures to localize disease, and digital or toe pressures, especially crucial when ankle arteries are calcified.
Then we added stress.
Stress testing, treadmill exercise, or reactive hyperemia to see how the system performs under load, revealing functional limitations.
And volume changes.
Plethysmography, mainly pulse volume recording, key VR, looking at waveform shapes at different limb levels, plus digital plethysmography for toes, less affected by calcification.
And finally, the microcirculation test.
Yeah, things like TCPO2 measuring tissue oxygen and laser Doppler assessing superficial flow or measuring skin perfusion pressure, getting closer to tissue level effects.
So it's clear, even with fancy imaging around, these physiological tests give us incredibly valuable objective information. They're not just pictures, they tell us how things are working.
Exactly. Diagnosing PE, understanding how bad it is functionally, guiding treatment, predicting healing, planning surgery. They answer crucial hemodynamic questions. Absolutely essential tools in the vascular lab.
Truly indispensable. This deep dive really highlights the science behind assessing circulation. And it definitely leaves you thinking, given how tied vascular health is to everything else, what lifestyle choices, what proactive things can we actually do to keep these peripheral arteries healthy throughout life? Something to ponder the risk factors and prevention. Thanks for joining us on the deep dive for this exploration.